Good afternoon. My name is Terry Nerney. I'm with Elsevier, one of the sponsors here today. For those of you who do not know who Elsevier is, we are the world's largest publisher of medical information for both nurses and physicians in the world. We roughly publish around 25% of the world's medical content. And we do deliver that content in a variety of areas that touch pretty much every corner of clinical healthcare. So the first area that we touch is clinical reference and decision support for physicians and nurses. Number two is patient engagement. So we do provide videos and information for patients so they can be informed of their care. Learning and competency management for nurses. So to make sure that your nurses are clinically trained properly to provide the best care possible. And we do provide clinical practice, so we have order sets and care plans that we can embed into any EHR. And lastly, we do provide information to nursing schools as well as medical schools as well. But without further ado, I want to introduce Pial Day from Sensio Systems. Dr. Pial Day is a co-founder and CEO of Sensio Systems. She leads Sensio Systems with the vision and passion for a world made better through intelligent information systems. Prior to Sensio Systems, Piali was an engineering fellow at Raytheon's Integrated Defense Systems. At Raytheon, she invented a system called Confluence, designed to deliver knowledge-based decision support in military and public missions. She was responsible for managing Raytheon's knowledge-based decision support business area. Piali is an author of many publications, 2 patents and 1 pending patent. She is a co-inventor of Sensio's patent-pending SIO framework. She is a member of Phi Beta Kappa, Sigma Psi, and Sigma Pi Sigma honor societies. Piali received the National Women of Color's 2009 Technology Innovation Award. In 2005, Piali received the Raytheon CEO Award, Raytheon's IDS President's Award, and Raytheon Business Development Excellence Award for her work on profiling Marine Corps missions. Piali and her husband, Dr. Hugh Stoddard, are proud parents of 2 sons, Kieran and Brenton, and all 4 share a passion for travel. So without further ado, Dr. Piali Day.
That was more information than you probably needed to know about me, but thank you for the welcome, and I'm delighted to be here. So what I'm going to talk about is going to, I think, dovetail very well with what Jeff just talked about. And I'm going to focus more on technology, but addressing the type of problems that we just heard about. And I'm going to introduce you to a concept that we're calling digital therapeutics, primarily to sort of bring some differentiation into all the work that's happening around digital health. So, I mean, of course, this is the essence of why we are here. Payment reform and digital innovation is driving tremendous transformation in healthcare. And it's just so much that's going on. I thought what would be useful today is if we could wrap our head around a framework that allows us to think about all the things that are happening out there in relationship to each other, so that everything we're learning can itself become actionable. And that's kind of my focus with today's conversation. So just a little bit of definition. Digital innovation is all about using health data to improve healthcare decisions. So if we're going to do that, so let's just think about all the type of data that is out there. And I know the semantics on this perhaps is also not universally understood, so I'll just quickly say what I mean by it. The claims data is who's been utilizing what kind of healthcare. By clinical data, I mean the data that the physician is creating, the diagnoses, the prescriptions, and all that. And then there is the patient-reported data. So those are the sort of the world we have available to us to utilize as data to inform better decision making. So let's look at the various ways that we've been doing that. If you take the claims data and the clinical data, we're seeing, of course, incredible advances in predictive analytics. And I wanted to just take a stab at concisely trying to define what does that mean. And the way I think about it, and I know it's open to discussion, I mean, we should be challenging each other's definition, because we've got to come to some understanding about what does all this mean. So what predictive analytics means to me is who's at risk for what disease and why. And this is that population segmentation that Jeff was talking about. You know, who's at the tip of my pyramid, costing a lot, who's in the middle, rising risk, and who's kind of leave them alone. They're doing just fine by themselves. So who's at risk and why? And also down the road, predictive analytics is going to tell us what therapies are working for the people at the tip of the pyramid, but this particular group at the tip of the pyramid versus this particular group at the tip of the pyramid, so that we can start to compare those groups and recognize perhaps it's a genetic attribution that is differentiating the outcomes there, or perhaps it's environmental, perhaps it's socioeconomic. But down the road, by better utilizing data, we're going to be able to know which therapies are working for who and why. The next level of digital innovation is in telemedicine. And telemedicine is primarily using clinical data, a doctor's knowledge about what's wrong about the patient. He's got hypertension, COPD, tends to present himself in these ways, along with some patient-reported data. And the patient-reported data in this case could be a remote patient monitoring system, your glucometer transmitting data constantly, or it could be a visual on the patient with a Skype device, remote ECG device, a remote blood pressure monitor. Doesn't really matter, but there'll be some patient-reported data that's being combined with the physician's expertise and knowledge about the patient to really do remote diagnosis. So the beginning, the first part, predictive analytics, is about who's at risk. I'd like to think about the telemedicine as what's their problem. And you need to know both of those, and all of that is actionable. If I know who I should focus on, well, I should go focus on them. If I know what problem they have, well, I know that I need to take care of those problems. But the thing that's still missing from this equation is what I'm calling digital therapeutics. And we're defining that as knowing when to act and why you should act now. So let's go back and think about it. Predictive analytics is telling us who to focus on and why. Telemedicine is telling us what's their problem, what is the problem I need to solve. But if we also knew exactly the moment in time that I needed to attend to a problem and create a treatment just in time, the early intervention, well, that is now starting to really just address the fundamental problem of successful management of people that are living with great risk. So just a little bit of humor here. This is the simplistic way to think about medicine's evolution. Very early on, it was all mind over body. I'm sorry you feel the pain. Let me just soothe you, and hopefully you can continue to live on with some quality of life. Today, of course, we're taking care of everything with medicines and surgery. Fantastic. Longevity has gone up. It's absolutely fantastic. But the future that I think we're all working towards is we could do better, and this is how we can do better. What if therapy could be constantly adjusted and absolutely precise? Right now I need this dosing for whatever ails me. Tomorrow I might need a different dosing. But what if all that could be adjusted constantly? And that, I think, is the precision medicine future we're moving towards, and you can't do that without data. You can't do that without constant analysis of data. And I think that's what we are all working for. So just a little bit further on understanding where is it that we still need to focus our attention. Of course, we're world class in the US at coming up with treatment plans. Okay? There's hardly anything we cannot cure. I mean, yeah, there's some things we can't, but we're awesome at figuring out how to cure people. And we're also getting better at care management. But our care management today still is somewhat reactive. If I were a care manager and I was told that a certain patient has a problem, I'll jump in, I'll take care of it, I'll coordinate that care, I'll vector the right resources to attend to it, and that's great, because we have to react when there is a problem. But wouldn't it be nice if we could anticipate all of these problems and actually be proactive? Why not do care management before something blows up? It's kind of like, I'm a parent, raised some kids, and I could wait until my kids are in an absolute fist fight, right? Hard a problem to solve. Or I could just kind of listen to those voices rising and the little bit of squabbles about who grabs that next piece of Lego, and I can jump in there and distract them and solve the problem. That's proactive parenting. And I think, we could do a whole lot more in healthcare if we could get care management to be proactive. So huge place to leverage benefits still in terms of proaction. But there's also an incredible resource out there that is still very untapped and underutilized by the healthcare system, and that is self-management. We can get so much more out of the people we care for if we empowered them and tooled them to improve their self-management. So the focus of what the problem that I spend a lot of time working on is in how to optimize self-management and how to make care management proactive. And it's my belief that this is the biggest weakness in our current healthcare system, and that this is what is causing the 5% of the population, those at the tip of the pyramid that we just talked about, to cost 50% of the healthcare cost. And this is the problem that is mostly addressed by digital therapeutics. So what then constitutes digital therapeutics? I'm just going to define it. I kind of threw the word at you, so I can just also throw the definition at you, and we can debate about it, whether it exists, should exist, or we should just not even talk about it. But digital therapeutics to me is just-in-time care delivery. Just in time. Reminders and instructions, okay? Motivation and feedback. Come on, you can do this. We believe in you. Connectivity to the care team. I may be in denial that I should be talking to my doctor today, but because my calendar is full and I'm on the road. But if digital therapeutics told me, don't get on the road and talk to your doctor today, and if I actually paid attention to it, perhaps I would do better. So connectivity to the care team, symptom recognition. We all live in denial because we got busy lives. We don't want to believe we're getting sick. What if a system could recognize the symptoms for us and logically told us, look, here's your problem. I can see it. Do something about it. And then precise intervention. That's the bucket that we're talking about as digital therapeutics. So I want to now introduce you to Pauline. She's actually one of the people who are part of our care management program. She has 3 or more chronic conditions. She has 15 plus medicines she takes a day. We have folks who take 45, 50 medicines a day. Incredible. Absolutely incredible. She ought to be monitoring a lot of things about herself because she's got COPD, she's got diabetes, she's got hypertension, and she has congestive heart failure. And it is absolutely overwhelming for her to not just do those things. Doing is easy. The hardest part is interpreting it. What does it mean? And that very notion that I have to think about, what does all this mean, is what motivates me to not even track it. Because that's hard. And of course that also leads me to not be in denial. But as a result, so a lot of observations are not happening about her, a lot of interpretation is not happening about her, and she ends up using the hospital system unnecessarily. So what makes Pauline's health very complex is Pauline not only has all these physical illnesses, but on top of that, Pauline has mental illness. She's quickly approaching dementia. But a segment of the population that we do care management for actually are younger population with extreme issues around anxiety, and bipolar and schizophrenia are areas we are getting into. On top of mental illness, we are also addressing cognitive challenges. We have about 60 people out in South Dakota who we are managing under their state's Medicaid program for cognitive disability, congenital intellectual disabilities, developmental disabilities. And all of that, this is additive. I can't just address the cognitive disability because cognitive disability is interfering with physical well-being, with joy and happiness. And oftentimes these folks also have socioeconomic challenges. So our premise is that all of these people need to be cared for under a single integrated care plan because it's one person. And not just that, there needs to be continuous support and oversight for this population, driving habituation and proaction. Again, think about this as the folks at the tip of the pyramid. Let's start there, let's see what digital therapeutics can do for them, and then we can move down in the pyramid depending on where the return on investment actually starts to make sense. But we can start at the top and serve those people who actually need constant support and oversight all the time. And the only way we're going to get them constant support and oversight is through artificial intelligence. I mean, let's face it, there is just no other way to do it. I can surround Pauline with folks who take 3 8-hour shifts, but that's not going to solve the problem. When the first shift leaves, there's a lot of knowledge transfer that's gone with shift 1 and not present in shift 2. The only way you're going to make Pauline's care continuous is through use of artificial intelligence. And it's not very far-fetched. We're using artificial intelligence to do so much. What we are trying to do at Sensia, and what I believe we have done, is to create a system that has about the intelligence of a first-year medical student. Put them in the house, $5 a day, okay? Who is not going to want a first-year medical student who isn't nagging you, it's not invading your privacy, is digitally embodied, and is watching over you? So a little bit about IBIS. This is our intelligent digital therapeutic solution. So it begins with, or actually a component of it is passive monitoring of movement. So when I don't feel well, what's the first thing that I do? I don't get out of bed quite as with the alacrity with which I do, and on other days I drag my feet, I take longer to get ready and get out of the house. So movement is actually the first place where the fact that we're not feeling well manifests itself. So we passively monitor movement. Second thing is we have a highly interactive and engaging device that we give to people like Pauline. It activates Pauline to do everything she needs to do, take her meds, take her meals, monitor her symptoms, see if she's doing them all in the right order. We tell them, of course, in what order to do things, but there's something that's checking in on the client and watching the client's self-care behavior, and we collect data from physiologic devices. And then we combine all of that through our artificial intelligence engine, which seeks a series of patterns. And these patterns are very individualized. So 2 people with COPD may not have the exact same trajectory to what we call the loss of control event when you have exacerbated. For some people, it would be manifested primarily through a worsening cough. For someone else, it may be worsening breathing. And how it shows up in your symptom could be different, but the artificial intelligence is going to learn it and will watch for your path to loss of control. And then that becomes actionable because there's a chain of logic that we can surface up and say, for these reasons, we think Pauline is in the middle of a COPD exacerbation. And when that happens, we present that data through all sorts of web media. We send text messages, and the care management team can then, with proof in their hands, know that this is a moment to intervene and actually intervene. And what this is, at the end of the day, is an example of the Internet of Healthcare things. And this is a field that's going to enormously grow. So let me tell you a little bit about how this all works. We basically have 3 artificially intelligent components inside IBIS. The first is a virtual nurse, someone who is just going to drive habituation. And so the way the virtual nurse drives habituation is by interacting with Pauline through that very easy to use on touch screen, easier than your microwave for sure, and as easy as your ATM. It makes a sound when it's time for Pauline to do something. Pauline comes in, it tells her what to do, she does it. If it tells Pauline to measure her vitals, she pulls out her cuffs, she measures her vitals, she reports the value, or we can take it from the Bluetooth device. And then Pauline also carries this wearable with her. That wearable communicates with the receivers throughout the house. We can ascertain movement patterns with an accuracy of a foot. So we really can tell whether you spend that half hour you usually spend in the morning enjoying preparing your breakfast and eating it, or whether you skipped it, or whether, it just took a lot longer today. So we accurately are monitoring movement. And all of that is going back up to our intelligent cloud, where there's a virtual care manager. And this is where we really resolve the alert fatigue, because we're not alerting on every single thing that's happening. We're looking at all the data in context, and we're interpreting it to say, do I have a COPD exacerbation that's about to blow up in our face? Do I have a fluid retention problem that's about to blow up? Am I seeing a pattern that is indicated that somebody's getting into a depressive state? And so it is really those things you want to know that is constructed by the artificial intelligence. And when we detect that, we notify Pauline's care team. This member of the care team actually is our employee. So Amy calls Pauline, make sure Pauline knows that Amy is on top of her situation, that Amy recognizes that Pauline is starting to go down the slippery slope, and that Amy will follow up with Pauline's cardiologist or pulmonologist and turn this over for clinical attention. And this is how we address the alert fatigue. So we don't ignore the problem that is emerging in the house. We synthesize it, we make it actionable, we get it verified, and then we hand things off to the clinical system. We're seeing some very high impact. 100% of our patients think that this is it. I mean, I can now take care of my health. And just having that confidence is a battle won. Second thing is we're seeing an incredibly high adherence to care plan, 85% plus. And this isn't just med adherence. We're seeing about 100% compliance with the med adherence. But this is adherence to all the symptoms that Pauline is supposed to measure, which she never did before. And of course, if she isn't tracking her symptoms, how is anybody going to know that she's not feeling well? Okay? So 85% plus adherence to the care plan. We're detecting actually 100% of the exacerbations in the home, but I didn't want to put 100%. I mean, there'll be some that'll slip away. Maybe we didn't ask the right question. But because these people are monitoring all their symptoms and we're able to interpret all the system, we're picking up these exacerbations. And as a result, we are seeing fewer hospitalization. The 20% is kind of my guess for the overall population. We have a mix of people, and for them, we are seeing 20% fewer hospitalization. But the one I want you to focus on is the result we're seeing at the Central Maine Medical Center. Over a one-year study, we saw 70% reduction in COPD hospitalization. And the only ones that got away are the ones that happened over Friday night or Saturday night, when the doctors weren't there to adjust their medication. So this is preventable. This is totally preventable. This is really what I think complex care looks like in the future. Let's detect things early on in the home where you can treat it. It's treatable by medicines in the home. So just a little bit more details about why IBIS is effective. IBIS is effective because it's picking up these exacerbations. So over 23,000 patient days, we picked up 243 COPD exacerbations. The one that surprised me is the hyperglycemic exacerbations. And we're still not doing much with them, but we're just about to start a randomized control trial with the COPD population in Central Maine. And the people those COPD population that also have diabetes, we're going to run a joint care management program with endocrinology over there. So we are going to start to address some of those. But basically, we're interpreting all these telltales, no false alarms. Because, the doctors tell us, here's what I want you to look out for. I mean, if they were there, that's what they'd look out for. And they'll make the same decision the system's making. So the doctor tells the system what is it that the system should be looking out for. The system looks out for it, and then we let the doctor know that we've detected it. And this is the story. This is really the reason for our existence. So what this shows us is about 2 years of results at Central Maine Medical Center. They were our first customer, and we just absolutely love them. We're doing fantastic things together. The first year, which is really from here to here, all we had was the habituation piece. So we were telling Pauline, hey, you need to do this, you need to do this, and Pauline was doing everything she needed to do for herself. November 1st of 2015, we introduced a COPD exacerbation detection protocol. It took us a year to work with Central Maine, with their head pulmonologist, to figure out, okay, it's now that we know what all these symptoms are, how do we want to interpret these symptoms so that we know that Pauline is getting into trouble. It took us a year, we put it out there, 16 hospitalization episodes for this population leading up to us putting that early detection system in there, 2 hospitalizations since then. And they both happened on about the same day, and I had to look whether that was a weekend or not. And we've had no hospitalization since then because their pulmonology department is taking us seriously when we fax them a sheet of paper that says, here are all the symptoms that that led us to believe that Pauline is exacerbating, and Pauline did everything you told her to do. So one of the things we do is when we detect an exacerbation, we ask them to take extra oxygen, cough, try to clear their lungs, take the nebulizer. Now it turns out most people don't remember how to take their nebulizers if they're only taking it occasionally. Central Maine Medical Center made a video for the 10 types of nebulizers that they prescribe. So we play through our care station your nebulizer, so you're reminded at the moment on how to use your nebulizer. You use your nebulizer. All of this is clearing out most of the exacerbations. But those that are not getting cleared out, that's when we send a fax over to the doctor's office because that needs a med adjustment. They are making the adjustments to the steroids or the antibiotics, and it's taking care of everything in the home. And that, to me, is the last mile promise of digital therapeutics. And I guess I'll just finish with a quote from Richard Goldstein. I mean, he said this about 2 years ago, probably, when he just first decided to become our customers. We've come a long, long way since then. But I truly believe that this is how the world of medicine will change for those at the tip of the pyramid who are really having to work very hard to manage their complex health. And the reason we can't help them more than we do is because we don't know what's going on in the home. But there is a way to know what's going on in the home, and we're proving it. Thank you. I think we're supposed to do questions.
Yeah, that means you guys know.
Yeah.
So I have a question for Dr. Day. Two questions actually. One is, are you getting any pushback from the family around, or the patient, about having all of this technology and Big Brother watching you in the home? And the second part is, are you doing anything with dementia patients to look at wandering at night and some of those behaviors that are, to get them back on track?
So to answer the first question, we were getting a lot of, we were getting about 30% of the population pushing back on, no, I don't want this in my home. It feels like you're just, watching over me too much. But when at Central Maine, the pulmonologist started to tell the patient, and we have a recipe for picking who this will benefit, and say, look, I'm giving you your meds, and I really just need you to also add this digital therapeutics to your regimen so that I know when you're in trouble and I know how to best address the problem. Then all of that argument went away. So now we don't get a pushback about that at all. The family members are not yet as involved. Central Maine Medical Center decided not to involve the family members, so this is just between the doctor and the patient. But if the doctor tells you, I need you to be doing this so that you can take better care of yourself and I can take better care of you, that argument around privacy it goes away. And of course, we're very mindful. The movement data, for example, we don't share with anybody. All we do with the movement data is we're looking for change. Are you slower today than you were before? And then what we do is we start to then query, how's your breathing? Because if we slow down, if I'm a heart patient or a lung patient and I'm slowing down, chances are I'm having a harder time breathing, so I'm just preserving my breath. So we just use that information to more intelligently query the patient for the symptoms that then help us do that early detection.
So you don't have a lot of dementia patients with early, or it's a comorbidity?
Yeah, we haven't done a systematic study with dementia patients. Quite a few of our patients have dementia, but it's a loved one in the house that's assisting them with the technology. I'd love to do a study as to how far into dementia can someone still continue to self-manage themselves. The closest thing we come to that is we have some intellectually disabled population in South Dakota, and so we know that we are enhancing their independence, but I don't have a systematic analysis of what that looks like.
Two questions. The first is the analysis system, the risk evaluation. And you've given the example here of COPD. COPD involves a lot of different things and coexisting conditions. I take it, I mean, you say AI, and what I'm taking out of this is a supervised nervous system. And that basically you're taking a patient profile, and then over time, because you are getting feedback, okay, you are refining the algorithm for which that particular patient is suited. My question about this is,